right? So today we've again, meeting with another session, and we'll be taking this as a case-based learning, or which we also called as a problem-based learning, right? So let's get started, and I'm your mentor at an academy, Dr. Reena Kaur. So, you know that these questions are going to be there for your exams, like we had discussed initially in last week also. Similarly, this is going to be another case-based learning where we are going to take CNS today. So before I just get started with this, I just give you a review with what are we coming up now on an academy, right? So remember that you can enroll yourself using the code REAP9 for more of the events and for more of this ultra compact which we are coming with. All the FMG students, please set back. You can use the code REAP9 again to please give on this exam, All India mock test for your revision. And we are now coming up with more, down prices. And we're also starting up with our second prof package. So let's come up to the case today, and I think I want all my students to tell me what is this case, right? So there is a 34-year-old woman who is coming with a history of seizures, and she is presenting to the neurologist that there is difficulty in walking and coordination. She has been on phenytoin for several days, right? She has been on phenytoin for very much days. This is the drug which is being given to treat her. That is now being switched to valproic acid. She has given a history that there is a change in the gait, speech. There is also blurring of vision. She gets tremors with movement. So this is a very, very important clue that there is tremors with movement. And apart from this, there is loss of hand coordination. So another clue that is given is hand coordination. She never had such symptoms initially. She does not have headache or vertigo. On examination, the women is with an unstable gait and a poor hand-to-eye coordination. She's having a tremor, nystagmus and a fine tremor when she is moving it. Urine drug test is negative. CT scan, lumbar puncture are negative. So what is this patient suffering from, right? What is she having? Now, obviously, here we have given the answer that it is being diagnosed as cerebellar ataxia. But remember, whenever you are getting a history of intention tremor, what is intention tremor? That means there are tremors when the person is trying to do something. There is any movement, he's picking up a pen, whatever with that. So if there is any movement, at that time there are tremors, that is called as intention tremors. These intention tremors go with your cerebellar disorders. Second important thing, if there are resting tremors, right? Resting tremors. That means the typical pill rolling movement. So if this type of a history is given, it goes more with Parkinson's. That is the lesion of the basal ganglia. Apart from this, you must remember there can also be tremors and anxiety, which are called as your fine tremors. So tremors and anxiety or hypothyroidism are your fine tremors. So this is the history of a patient who is suffering from some cerebellar ataxia. Now, what are the possible questions I can get on this question? Or if I'm given a clinical history, what possible questions I can give? You can be asked which part of the cerebellum is responsible for planning and initiation of movements, that is for planning and programming of movements. Then I can ask you what output of the cerebellar cortex is, whether the cerebellar output is excitatory or it is inhibitory or it is both. Or the next question can be neurotransmitter of the Purkinje cells. So these are the various questions, or I can even ask you the test for cerebellar lesions. That means if you want to test your cerebellum, what are the different tests for the coordinations you can get in your exams. And apart from this, obviously, when you study your anatomy, you will be knowing the different inputs, right? And the functions of cerebellum are important in this, right? So first we'll try to, compile the answers which are asked to us, like the part of the cerebellum that is responsible for planning and initiation of movement, that we called as planning and programming of movement, is our neocerebellum. The output from the cerebellar cortex is inhibitory, and the neurotransmitter from the Purkinje cell is inhibitory neurotransmitter, that is GABA. Okay, inhibitory neurotransmitter, that is GABA. So this is a 34-year-old woman which is developing cerebellar ataxia and lack of coordination. However, it is secondary to the medication. That means it is in the form of a side effect of a drug, right? But obviously, the symptoms are taking you close towards cerebellar lesion and not towards any other part of CNS. Now, whenever you study ataxia, that is swaying, the common viva question which is asked to you is, what is the Romberg's test? This is something very much commonly asked to us. What is the Romberg's test? So remember, the Romberg test is a test which distinguishes between a sensory ataxia and a motor ataxia. That is a sensory defect and a cerebellar defect. So in this test, you ask the subject to stand straight with feet together and eyes closed. If the person becomes unsteady because the eyes are closed, there is an indication that there is a loss of balance due to a defect in proprioception. Okay, due to a defect in proprioception, right? And if an individual has got cerebellar ataxia, he will be able to have balance, right? He will be able to have a balance even with eyes open, right? Sukhbir, 23, next is still on question. We are not yet confirmed that whether it is going to be, you know, really merging. So this is upcoming question, but we will have to solve it. This is not very much clear. This is not very much clear, right, Sukhbir? Okay, so this is the Romberg's test. If there is swaying with eyes closed, that is a defect in your proprioception. And if it is cerebellar ataxia, then even with the eyes open, the person is unable to keep his balance. Now, just look on to one or two MCQs before we start looking into the theory. Which of the following statements concerning the general function of the cerebellum is correct? See, you have to find out the correct statement. Options: the cerebellum directly stimulates the motor neurons which are required to make a movement. The cerebellum is unable to make corrective adjustments to the movement once it is performed. The cerebellum does not receive feedback from the muscles that are executing the movement. The cerebellum is not involved in the planning of the movement, only execution. Or the cerebellum plays an active role in coordination of the muscles that are required to make the movement. Yes, anyone can come up with the correct answer. What could be the correct answer here? Yes? Yes. So the correct one is E. Right? The correct one is E. The output of the cerebellum is quite removed from the motor neurons. Okay? And we will now study how the cerebellum is influencing. Which of the following statements describe the functional role of the lateral hemispheres of the cerebellum? Controls and coordinates movements of the axial muscles and hip and shoulder. Controls the movements involving the distal limb muscles. Functions with the cortex to plan the movements, or stimulates the motor neurons through its connection to the spinal cord. Yes, which of them is the correct option for lateral hemispheres? Anybody can make a guess? What is the function or what is the role of the lateral hemisphere of the cerebellum? So, the lateral hemisphere of the cerebellum is taking a part in planning the movements along with your cerebral cortex. Okay, now we look on to the cerebellum. See, this is your cerebellum, which is having this lateral zone. This is the posterior lobe. This is the flocculonodular lobe. This is the vermis, and the area which is adjacent to the vermis are your intermediate zone. When you look over to the anatomical division of the cerebellum, right? This is the anatomical division of the cerebellum, where you have got an anterior lobe, the posterior lobe, the flocculonodular lobe. And this is the anatomical division of the cerebellum. The lingula, central lobule, culmen, declive, folium, tuber, pyramis, uvula, and nodule. As far as your physiology is concerned, right? As far as physiology is concerned, we are going to divide the cerebellum as per its physiological functions. So in physiology, we basically consider cerebellum as physiological functions of cerebellum, and we are going to divide it functionally. So this in anatomy, which we called as the flocculonodular lobe, will be called as the vestibulocerebellum. Vestibulocerebellum, right? Then this portion over here, which is including your vermis and the intermediate zone, physiologically, this will become your spinocerebellum, and this laterally, the lateral hemispheres are your neocerebellum, which we also called as the cerebrocerebellum. Okay, cerebrocerebellum. Phylogenetically, the oldest part of the cerebellum is vestibulocerebellum, which we also called as archicerebellum. Spino is also called as your paleocerebellum, and cerebrocerebellar is the neocerebellum. So once you are knowing these three lobes, you must know directly the functions of each part. So if you look into the function of your lateral, that is the neocerebellum, it is involved in the planning and programming of movements. Now this is the specific function of neocerebellum, specific function, right? Because this function is not going to be performed by the spinocerebellum or by the vestibulocerebellum. The function of the vestibulocerebellum, as you see the name implies, it is connected with the vestibular apparatus. So it is basically concerned with your balance and equilibrium. Balance and equilibrium. As far as this paleocerebellum is concerned or the spinocerebellum is concerned, this is also called as our comparator servo feedback mechanism. Comparator servo feedback mechanism. It is involved basically in the smoothing and coordination of movements, right? In the smoothing and coordination of movements. And what is comparator feedback mechanism? See, it is receiving a copy of the movements from the cortex. That means the cortex is going to execute the movements through the corticospinal tract, and what the muscles are performing, what movement is going on. A copy of this is provided through the various tracts, the afferent tracts to the spinocerebellum. And the spinocerebellum is going to compare the ongoing movement with the movement that is performed. Okay, suppose you have to pick up a pen. So this is the movement that is planned, and suppose there is any disparity between the movement that is planned and the movement that is executed, it is going to be corrected by the spinocerebellum. That is called as the comparator feedback mechanism. Now, this is your cerebellar circuitry. You know that the cerebellum has got three layers. The granule cell layer, which is the innermost layer. Okay, the granule cell layer, which is the innermost layer, which has got granule cells, Golgi type 2 cells, granule cells, Golgi type 2 cells, and this is what is called as the cerebellar glomerulus or the cerebellar glomeruli. This cerebellar glomerulus is made up of these mossy fibers. The mossy fibers are what? They are the spino and the pontocerebellar tracts. The spino and the pontocerebellar tracts. So these inputs which are coming into the cerebellum, which forms your mossy fibers. These mossy fibers are going to form a cerebellar glomeruli with the Golgi cells and with the granule cells. So you have got the Golgi cells, the granule cells, and the mossy fibers which are forming the cerebellar glomeruli, right? So this is the innermost layer, that is the granule cell layer. Then the middle layer, which is mainly having the Purkinje cells. And you know that something very important regarding the Purkinje cell, the neurotransmitter of the Purkinje cell is GABA, and the output which is given from the Purkinje cell is to the deep cerebellar nuclei. Okay, it is to the deep cerebellar nuclei, which is always inhibitory because the neurotransmitter itself is inhibitory. Apart from this, now you've got the outer molecular layer. You can see that the outer molecular layer will have your basket cells, it will have the stellate cells, it will have these parallel fibers. These parallel fibers are nothing but they are the axons of the granule cells. Okay, they are the axon of the granule cells. So the cerebellar cortex having three important layers and the cells in it. Now you will see that we study in synapse that cerebellum shows a feed forward inhibition, right? So the feed forward inhibition is an example which is seen in the cerebellum. So you see that the granule cells, they excite the stellate cells, but the stellate cells and the basket cells in turn inhibit the Purkinje cell. So A is stimulating B, but B is inhibiting your C. This is an example of the feed forward inhibition which we are getting in our cerebellum, right? Now, if you have been studying, you know that the excitatory inputs to the cerebellum, are your mossy fibers and your climbing fibers, right? The climbing fibers, they are originating from the inferior olive of the medulla, originating from the inferior olive of medulla. The climbing fibers, they show 1:1 cell connection with your Purkinje cell. Okay, 1:1 cell connection with the Purkinje cell. And the climbing fibers, they are going to form a complex spike, right? They are going to form a complex spike. Whereas the mossy fibers, these mossy fibers are the inputs which are coming from the vestibulocerebellar, then your spinocerebellar, then the pontocerebellar. All these tracts or all these fibers, they are actually what are the mossy fibers which are coming to the cerebellum. So this mossy fibers and the climbing fibers, they are the excitatory inputs to the cerebellum. You know that the mossy fibers, they stimulate the granule cells, and the granule cell is then what forming the cerebellar glomeruli. Apart from this, mossy fibers can also directly stimulate the Purkinje cells, right? They can directly stimulate the Purkinje cells. And the granule cells, they are giving the parallel fibers which also stimulate the Purkinje cells. Okay. So the granule cells, they give the they give the granule parallel fibers, their axons, which can stimulate the Purkinje cells. The mossy fibers are also directly stimulating the Purkinje cells. And you will be surprised to know that in the case of the climbing cell and the Purkinje cell, you are getting a complex spike and 1:1. So one cell, one fiber. But about, around 2 lakhs 50,000 parallel fibers. These many fibers can be converging towards one Purkinje cell. Okay, these many can be converging towards one Purkinje cell. And the mossy fibers to the Purkinje cell, they form a single, that is a simple spike. Okay, they form a single, that is the simple spike. So the mossy fibers, they are forming a simple spike, whereas the climbing fibers, they form a complex spike. Now, what is the importance of this so much of inhibitory input, right? See, you can see that there is so much of a complex circuitry in the cerebellum. What is the need of the cerebellum to bring about such complexity? The need is, or the advantage is, that these type of the inputs which are inhibitory and which is it is maintaining is actually responsible for a very important role of cerebellum. We know that the cerebellum is important. The cerebellum is important for the rate, range, for the force of movement, for the direction of the movement, right? The rate, range, direction, the force of the movement, that is the proper synergism between the agonist and the antagonist. Okay, a proper synergism between the agonist and the antagonist. So this is the most important role of a complex cerebral circuitry. Now another MCQ, the activity in the climbing fiber does which of the following? Activity in the climbing fiber. It causes release of GABA from the climbing fibers. It evokes a complex spike in the Purkinje cell. It has got no effect on the flocculonodular lobe. It is going to excite the neurons in the deep cerebellar nuclei, or it weakly depolarizes the Purkinje cell. So what is the correct answer? Just now I told you that the complex spike is being formed by the climbing fibers. So when the climbing fibers are making a synapse, they form a complex spike in the Purkinje cells. So a single action potential in the climbing fiber is going to evoke a complex spike in the Purkinje fibers. The complex spike is activated by glutamate. Now, what is the advantage or what is the role of this complex spike? We will try to understand when we study the functions of the cerebellum. Like when you want to enumerate the functions of cerebellum. Now, as we have seen that it is showing a very, very important and a complex circuitry that is going on in the cerebellum. The first very important function of the cerebellum is, apart from the specific function. So we have learned the specific function, that is planning, programming, balance, equilibrium, and smoothing and coordination of movement. That is the specific function, no doubt about it. But when we have to write an LAQ, when we have to write an LAQ, at that time we have to know in detail the functions of the cerebellum. So you know that the cerebellum is involved in coordination of movements and motor learning. So it is involved in the coordination of movements and motor learning. Like when you are learning new skills, new procedure, you require cerebellum. Now the parallel fibers, it is very, very important to correct the movements. See, you have got parallel fibers and you have got the parallel fibers that are giving inputs to the Purkinje cells, and you have got the climbing fibers. So these parallel fibers, they are coming from the granule cells, and the granule cells, we know that they are getting stimulated by the mossy fibers. These are responsible for the ongoing motor movements, right? They are responsible for the ongoing motor movements. Now, Suppose if there is any mismatch between the planned movement, okay, if there is any mismatch between the planned movement and the ongoing movement, what will the climbing fibers do now? These climbing fibers, which I told you that form a complex spike, they are going to cause a long-term depression. They will be causing a long-term depression of the parallel fibers. That means the ongoing movement will be corrected, and this is the basis. How does cerebellum brings about correction of movement? So the complex pipe is going to cause a long-term depression of the parallel fibers and correct the ongoing movement. Then cerebellum is very important for the initiation of the movements, for the termination of the movements, and as I told you, the rate and range of movements is also brought about by the cerebellum. It is very important for performing rapidly performing movements, right? Ballistic movements like throwing a dart, such movements which require fine skill are by your cerebellum. And flocculonodular lobe, as I told you, that it plays a very important role in balance and equilibrium. It plays a very important role, like it can make predictive calculation. The cerebellum can make, or the vestibular cerebellum can make predictive calculation about the movement speed and the any changes that are going to be performed in movement. So about movement speed of movement, so that the corrective changes can be brought about. That means the role of cerebellum in the motor movements is an example of, yes, it is an example of a feed forward type of a anticipatory correction. Like there is a positive feedback, there is a negative feedback. This is anticipatory feed forward correction it can bring about. Now, therefore, when you have got cerebellar lesions, right? When you have got a patient has got cerebellar lesions, the pure tone cerebellar lesion results in hypotonia. Apart from this, the patient has got intention tremors, nystagmus, nystagmus, dysmetria or past pointing. Dysmetria, which we also called as past pointing. That means the person is unable to assess, okay, unable to assess the depth or distance of object, or distance of object. So when we are performing this finger nose test, he is not able to perform this. Then there is decomposition of movement, okay, decomposition of movement. That means suppose if the person with cerebellar lesion has to reach up and pick up something, okay, reach up and pick up something, the movement will not be very smooth. He will perform the movement as if each and every joint is performing movement, so that smoothness will be lost because there is decomposition of movement. And due to the lack of coordination, the patient develops dysdiadokinesia, that is the alternate supination and pronation is lost. What is nystagmus? This is the jerky oscillations of the eyes, or jerky oscillations due to incoordination of the ocular muscles, okay. So this is jerky oscillations, oscillating movements because of the incoordination of the ocular muscles. What are the tests which we performed for cerebellar assessment? If you remember, we perform the finger nose test. We perform the finger nose test, right? Then, if you remember, alternate supination, pronation, adidokinesia. And for the lower limb, we ask for tandem walking. That means walking on the straight line. And we also for the lower limb do a heel knee test. A heel knee test. Okay, so the person is in the supine and the heel is supposed to slide along the knee of the opposite side. Now, these questions like enumerate the cerebellar lesions or the different test for the cerebellum, these can come as your 2 marks BAQ. As far as cerebellum is concerned, it is very, very important LAQ. And you can get an SAQ on functions of cerebellum. So cerebellum is a very high yielding topic, all the first profs, please remember. Now let's see another case. Okay, so this was the case with cerebellum. How did we diagnose? We diagnosed it because intention, tremor and lack of coordination was given to us. Let us look into another case. Now this is a 63-year-old man who is brought to a physician because he is concerned by the family members that he's acting differently. He's having a worsening tremor at rest. So see what I told you. Tremors even at rest are indicative of what? He has got difficulty in walking, difficulty in stopping, a mask-like face. Okay, mask-like face, pill rolling movements, rigidity, and a stooped posture. So all these things, where there is no symptom of sign of depression or dementia, this is the patient of Parkinson's. So Parkinson's will be a mask-like face, rigidity, right? Tremors at rest. Okay, to differentiate it from the cerebellar lesions. The person is having short steps as if he will fall towards the center of gravity, right? So what could be the questions you can be asked if the cases of Parkinson's? You may be asked which nuclei are there for basal ganglia? What is the basis of treatment of basal ganglia? What is the basis of treatment of Parkinson's? So you should know that the basis of treatment is that there is degeneration of the nigrostriatal pathway, right? There is a degeneration of the nigrostriatal pathway, dopaminergic neurons. So there is a decrease in the amount of dopamine. That is what is responsible. So the treatment is going to be dopamine agonist. Then as Parkinson's is with the lesion of the nigrostriatal pathway, there is hemibalismus. Hemibalismus can take place when there is a lesion of the subthalamic nucleus. Okay, lesion of the subthalamic nucleus. So this is another way a case history can be taken in the case of CNS. So cerebellum and basal ganglia are two important things where the case history can come to us, right? So thank you, boys and girls. So let me know that if the session was important, I mean useful to you through your comments. And you can also share with me more of your, more of your topics which we want to study together. So for now, I want that please be very, very patient and very, very, planned, because the time is up now. I think the exams are in the month of January. So please study well, make a proper timetable and ensure that you revise whatever you learn. And not only revision, how to write is also an art. Many of the people, they learn the answers well, but they're not good at writing. So as far as possible, draw flowcharts, diagrams to minimize your time so that your paper is completed, because the paper is really a lengthy one. So thank you and take care all of you.